See if there is a confusion. Good morning. Thank you for the invitation. Thank you, Vincent, for organizing this symposium. When I started preparing my speech, I thought you must not like me at all for giving me that topic because there's really a confusion. Anyway, challenge accepted. And we're going to try to take care of that confusion. Obesity, we have to talk about it because it's a true public health issue which is going to continue increasing. We consider that 15% of the population has a situation of obesity, 30% is overweight. In 10 years, we will have 25% of the population that will be obese. The problem with obesity is that it generates a certain number of diseases and a certain level of mortality. This is where bariatric surgery, which I don't perform, is growing. You can see the peak, really, that was at its highest in 2015. And then it came down a little because of COVID, and now we're pretty much at the same level as we were in 15. So you have the main interventions here, the ring, the bypass, which are two possible procedures. And then if you look at the perineum, well, you know that it's this muscle and ligament set that actually closes the pelvis and that only lets the urogenital and anal sphere come through. And so you have the anterior triangle, which is urogenital, and the posterior, which is the anal rectal area. The perineum is a structure that supports the pelvic organs. It plays a role in fecal and urinary continence. It also plays a role in the sexual function, and it also comes into play during birth or delivery. But the problem is that when the perineum is not right, you have all your organs that can come down. You have continence disorder, both urinary and fecal, and you have sexual disorders. So Vincent's question was how to combine all this. What's the impact of obesity on the perineum and on perineum disorders? Well, let's look at the question of the impact of obesity on a healthy perineum. Well, we know that every time you get an extra 10 kilos, you have the intra-abdominal pressure that increases. It is kind of multiplied 2 or 3-fold. So plus 10 kilos will give you plus 20 or 30 kilos in the intra-abdominal pressure, to which you have to have gravity. You cannot just ask obese patients to remain lying down or to just stand on their hands. It's also increased every time you cough or sneeze or carry heavy load. So the muscles are stretched and the nerves are stretched, plus systemic inflammation, which we observe systematically in the case of obesity. Obesity which leads to tissue alteration, including perineum tissues, and diabetes, that's a metabolic syndrome, and the metabolic syndrome which have an impact in terms of neuropathy or microangiopathy, and this also impacts incontinence. That's the morphological association. And then when you look at the diseases, well, then you have a lot of data on urinary incontinence or continence disorders, I would say. There was this Norwegian cohort that looked at women with incontinence, and it pointed to a significant link between urinary incontinence and BMI, right from the stage of overweight, and then it increases when your BMI increases. So obesity and overweight have an impact on urinary incontinence and on the different types of incontinence, stress type incontinence and mixed type incontinence, or your urge type. And we also have a French cohort with obese patients, 25,000 patients, which shows clearly that in an obesity situation, the rate of urinary incontinence is 35% versus 19% when your BMI is below 30. So for urinary incontinence is very clear. For fecal incontinence, we don't have so much data available because people don't talk about it so much. It's a bit of a taboo. But we do have this American series with more than 2,000 patients who looked at the fecal incontinence risk factors in women over 40. And what came out was clearly that BMI was a factor. And then you have more typical factors like COPD, irritable bowel syndrome, urinary incontinence, and colectomy. And I think that the fecal incontinence rate is at 35% for people who are obese versus 19% in general population, exactly the same numbers that we had in France on the urinary incontinence study. Pathophysiology in urinary incontinence in obese people is not so well known as for urinary incontinence. We do have a certain number of information. We have a French series from Rennes where they looked at factors leading to fecal incontinence in obese patients. What comes out of this is that there is a change in the texture of the stool with more liquid stool, which is probably coming from the eating habits with an alimentation of a diet which is richer in fat and not sufficiently rich in fibers. There is also a study from Brazil which shows that manometric data is different between a group of obese patients and a group of non-obese patients, with the tone at rest and the contraction pressure which are decreased. The problem is that when they looked at fecal incontinent patients and non-incontinent patients in the group of obese people, there was no difference in the manometry. So it's not that clear, actually. And then where it's even less clear, it's the impact of obesity on the disorders in pelvic tone. We have, in some studies, an impact that's been reported, in others not, no trouble. So the thing is that it's evaluated on the basis of scores. So we have no description. We don't know if it's a rectal prolapsus or anterior prolapsus. There is a great variety of things which are said, and it's difficult to be conclusive on that chapter. When you talk about impact of obesity on the perineum, you can also think about the impact on perineal surgery that might be performed to correct that. What comes out is that obesity doesn't really have an impact. It does increase the duration of procedure, but it does not improve the intraoperative or postoperative morbidity. It does not increase the number of re-surgery. There's just a question in terms of the number of recurrence. And maybe that's why Vincent gave me that topic, because we conducted that study in Marseille. In my ward, we wanted to analyze the impact of overweight and obesity on the outcome for the disorders in rectal tonus. So the operating time was increased, but there was no difference in terms of intra and postoperative complications. And when you look at the functional result in the long term, you have more recurrence in the overweight and obesity group. It's significant when you combine both versus normal weight. And for second intervention, you have more also in obesity versus normal weight. I haven't had the time to publish this study, but maybe I'm going to do that this weekend. Thank you, Vincent. Now, that was for the link between obesity and perineum. Now, I do have to talk about the impact of bariatric surgery on the perineum and the conditions that I just showed you. First of all, the impact of bariatric surgery or weight loss measures on the perineum. We have robust literature here. There is a US randomized trial, which is a reference on the matter. It compared different diets and exercise on obese and or overweight patients in terms of impact on their urinary incontinence at 6 months. What we do see is that after 6 months there was significant weight loss in the experimental group, thank God. And for what we were interested in the group that had lost weight, there was also significant decrease of the incontinence. And when you look at the detail of the different types of incontinences, stress or urge, you also have a significant improvement thanks to the weight loss. I was talking about bariatric surgery. There are a lot of observations which all go in the same direction. Bariatric surgery leads to an improvement in urinary incontinence. And this is why urinary incontinence is now an indication for bariatric surgery. You have the latest guidelines from HAS here in 2024, which mention that when disabling urinary incontinence does not correspond to the usual therapeutic modifications, you can have an indication of bariatric surgery. This is a real change, and it's the most robust data that we have about that. Now, when you look at fecal incontinence, we have that same American trial that looked at the subgroup of patients who also had a fecal incontinence to see if a change in diet was going to improve it. Well, the comparison is a little bit strange, but basically what comes out of this is that in terms of risk factor to improve on the accidental liquid stool, you have factor which is the increased fiber intake. So basically a change in diet will have an impact. If you look at bariatric surgery, you have a little bit of data here. This literature review shows that bariatric surgery would lead to an improvement in fecal incontinence, especially in women and especially in the case of a bypass. Here you see that you have an improvement after bypass, a decrease in diarrhea and constipation, but you also see that diarrhea actually increases if you use another surgical technique, which is duodenal diversion. And if you have a gastric ring, you see that constipation seems to increase. So all this is a little bit confusing, a little bit confused. You have this French series from Nice, which compared the sleeve and the bypass on fecal incontinence. Sleeve doesn't make a difference, while in this series it's the opposite. It seems that the bypass actually increases fecal incontinence, especially when you are looking at flatus. So here it's really confusing, and I'm sorry because I couldn't lift the confusion here in terms of bariatric surgery and pelvic organ prolapse. We have the impression that there's less prolapse after bariatric surgery. And then the last point is, does bariatric surgery improve sexual function? We have the same team here in Nice who looked at, after a sleeve or a bypass, if there was an improvement in the sexual function. And the authors reported that 18% of patients became sexually active again 1 year after bariatric surgery. And so they compared 3 groups of patients, those who are still inactive, those who always remained active, and those who go back to a sexual activity. And there's an age difference between the groups. But what is important in this trial is that you see a change when the BMI goes down by at least 13 kilograms per square meter. So that's pretty much what I wanted to tell you. Obesity and perineum, there is clearly an increased risk of urinary incontinence. This has been demonstrated. As for fecal incontinence, we are not so much aware of this because it's so much more of a taboo, but there seems to be an impact in terms of the texture of the stool and the dietary habits. For the prolapse, I haven't managed to solve that problem. And as for the impact of obesity on perineal surgery, it's only the duration of procedure that is increased, not the morbidity. There might be a little bit more recurrence. Bariatric surgery, urinary incontinence is an indication. For rectal incontinence, it's a little bit more confused. Maybe bypass leads to an improvement, but we're not sure. And we have an improvement in terms of sexual activity. And as for the prolapse, maybe you will have a little bit less of that after operating on a patient with bariatric surgery. Thank you for your attention. I want to remind you, and you are going to dream about this or to nightmare about this, there is a tripartite in September and the ESCP days in Marseille in November. Thank you for this beautiful presentation. We have a question in the room. Thank you, Jan. That was a great talk. You're a surgeon, so I feel safer asking you a question. When you have a patient, we've discussed that pelvic prolapse thing. You have an indication for rectopexia and an indication also of bariatric surgery. What will you go for? Will you first prefer bariatric surgery, thinking that maybe it's going to improve the prolapse, maybe with functional consequences, or would you go for surgery first? Well, I think you need to start with bariatry. And of course, you need to discuss that with the patient. I know that some patients want to get the problem solved, the pelvic problem solved, even before they start thinking about something else. So it's kind of a trade-off. You have to negotiate that with the patient. But of course, I'm unsure about the impact of bypass on fecal incontinence. It's not really clear. It's confusing. As Vincent says, in some articles you see an improvement, and in other papers, like the one from Nice, you see that there's more incontinence, especially regarding flatulence. So if I had to choose, I would go for bariatry first. I don't know what you do. Would you agree with that? Thank you. Do we have another question from the floor? I agree with the bypass because you see that the texture of stool is changing and they tend to have urges. So I want to refer to the protocol, which allows you to have weight loss without having to go all the way to bariatric surgery. Is there room maybe for those treatments? Oh, thank you, Nadia, for asking the question. I can't answer it, unfortunately, because it's absolutely not my area of competency, but I certainly hope that it will be the case. No more questions? Well, thank you. Thank you very much.